I run I run the Park Laboratory here at Penn Presbyterian Medical Center. We're an acute care research center, and we focus mostly on research pertaining to trauma and emergency medicine patients. Here at Park, there's always someone available 24/7 to respond to patients coming to the trauma bay and rush down there and assess the situation and enroll them in any of the dozens of different studies that we have. That's the clinical research part. And then there is the laboratory part where we can process all the samples, whatever they are. We can store them, and we can do analysis here and do some experiments if we need. So it's a very unique research center where actually there isn't really anything like us in the country. We were built to be versatile and adaptable, because we need to be able to do kind of any kind of experiment across all different disciplines of medicine. That keeps it fun for me, because I have to learn a little bit about everything from blood coagulation to bone healing to traumatic brain injuries, all these things that are new to me. This also keeps it kind of fun. So my research really focuses on mitochondrial function in immune cells following a trauma. And I'm working in the context of sepsis. So I work mostly, I did at least in the before times, I worked mostly with cells and biopsy tissue, and rarely interacted with patients. And that was really deliberate. I'm a lab guy. I'm kind of a loner. I put my headphones on, I sit at my bench, and I work all day without really talking to people. But all of that changed because of the pandemic. I and many others felt compelled to help in some way, and it took a lot of help and support to create what we built here, the COVID Trace Project. We're a mobile community COVID-19 testing project. This is kind of how it all started. For those of you that don't know what this is, I'm happy for you. These are the primers, and this is what's required to do the RT-PCR test. This is kind of where it all started for me. So in March of 2020, our lab was shut down, like everywhere else. All lab operations had to cease. Like many of us, I didn't know what to do. Just sitting around twiddling my thumbs, and we all watched this virus was ravaged through our country and communities. But early on, we understood quickly that testing and quarantining were going to be critical to getting this pandemic under control. Here at Park, we were talking, and we could all see that some communities were going to be neglected in terms of testing availability and resources. Now, this wasn't only because of location, but as Anna was mentioning, there are a lot of obstacles to certain populations receiving medical care. We kind of refer to them as medically disconnected populations. And they're disconnected for many reasons, not just for locations, but also because of cost or stigma or transportation or just distrust in outsiders and medical establishments. All understandable. So as a first-generation American, as an immigrant son, I am well aware of the healthcare disparities that plague our communities, and I know that neglect can be deadly. Like many others, I felt compelled to do something to help during this unprecedented public health crisis. But I'm just a lab guy. So when I learned that testing was based on real-time PCR, I thought to myself, hey, I bet I could do that. Yeah, with absolutely no idea what I was getting myself into, and a bunch of others, I decided to transform my laboratory into a COVID-19 testing lab. And I realized immediately how difficult this was going to be. The PCR part wasn't the issue. We have the equipment and the expertise. That's not the problem. I couldn't be prepared, however, for the complete lack of coordination between the government, the CDC mostly, and the companies that were charged with providing all of these supplies and reagents for these tests. The CDC presented its recommendations for the test, but allowed all of these companies to operate on their own without any standardization or coordination. So things like information, like primer sequences or PCR conditions or reagent concentrations, all of this stuff was different from company to company. That was very frustrating. Also, I was competing with every other lab in the world for the same supplies. And that just made everything much harder. And as for things like controls, there were essentially none available for a small lab like mine. So I had to figure it out. I grew up 2 human cell lines to act as negative controls. And then I had to finagle and plead for a couple of positive NP swab samples from the ER. And every step was like this. I was working alone in my lab and just getting frustrated every day. Yeah. Really, what kept me going was talking with all of these different people who went out of their way to help me build this. This included the people in our business office, the stat lab people, vendors, nurses, public health people. It was humbling. I've never experienced anything like this before. Indeed, this entire experience has been transformative. It really started a massive change in my personal and professional life that continues today. So here's our team, small but mighty. We're a pretty disparate group, but we came together to build this community project. I was completely out of my element at this point. Once I was outside the lab, I was lost. But luckily, I'm surrounded by very smart people who want to help. That includes Nabil Abdulhay. He was hired early on as the CRC, the clinical research coordinator for this project. He's since been promoted to program manager, and as of yesterday, as a dad. So congratulations to him. Rachel McFadden is a HUP ER nurse and has volunteered from the beginning. She has directed the clinical aspect of this project. Matt Lacchetto, who's not shown here, has also been a big part of the effort. I'll show him in a couple of slides. He's also a HUP ER nurse, and he's also a nursing instructor at Community College of Philadelphia. As part of his course, he brings some students to volunteer at our site, which is great. Ben Abella is a HUP ER physician and director of research in the Department of Emergency Medicine. So Nabil and Rachel are both passionate about social justice and contributed their energy, their empathy, and expertise to creating this amazing project. And I'll embarrass them a little bit here. I was and still am inspired by them. And this is a large part of what motivates me to continue with this work. Believe me when I say that there have been many times when I wanted to quit, when I was so ready to quit this project, but I knew that I couldn't let down our team. So in May of 2020, we started our first NP swab tests. I had written an IRB proposal for this research project, which sought to determine why certain populations were at higher risks for infections. Initially, we were targeting the Latino immigrant community and asking how well they could adhere to state and local guidelines for preventing infection. And those were things like, working from home and avoiding public transportation and, social distancing and stuff like that. Well, we were forced to shift our project somewhat, unfortunately, and we had to expand our population to include other medically disconnected and vulnerable populations in Philly. And so we partnered with Prevention Point of Philadelphia, which is a community clinic in Kensington area that caters to persons who are housing insecure and or maybe suffering from a drug addiction. So for this first year, it was just our small group going out every week and setting up a tent in a parking lot and testing people. I would then I would collect and process all the swab and blood samples in my laboratory and run the PCRs, and that was a lot. But we did this for a year through the hot summers, through the freezing winters in a parking lot, just by ourselves. I could tell you the last winter was really, really hard. Poor Rachel here was trying to draw blood and keeping her fingers warm. That is so hard to do. At the time, we were using paper surveys, and we were doing paper surveys, and I was the one that was doing most of the surveying, and I had to keep the pen in my armpit just to keep the ink from freezing. That's just the things that you don't expect. And all of this was super new to me, but we did it. So that for that first year, we were basically running on donations and volunteers. We set up a funding page in emergency medicine website, and we're just trying to make it work however we could. So that was the first, almost a full year that we did that. In June of last year, of 2020, we were awarded $500,000 by the city of Philadelphia to expand our testing site and to roll out the city's new rapid tests. They were using the Binax rapid tests. This allowed us to buy equipment and supplies and to hire people. This included hiring a lab technician, Jason Morgan, who's been working on all aspects of this project, but is mostly responsible for analyzing the samples in the lab. Thank goodness for him. So we've been running these sites since July of last year. And in December, we were renewed, our contract was renewed for another 6 months. So we'll be doing this to at least June. So we've been running since July, at least 3 testing sites per week throughout Philadelphia. These are the sites that are, these are some of the sites that we've done, they're shown here. At our sites, we provide free Binax rapid tests and real-time PCR tests from MP swabs. We were collecting blood and doing antibody testing, but we've had to stop doing that. But we also collect, as part of a survey, we collect demographic data and ask people about their experiences with COVID. Through our partnerships with the Philadelphia Department of Health, Prevention Point, and others, we are able to give out harm reduction supplies to members of these communities, including Narcan, some PPE, fentanyl test strips, all kinds of stuff. We partnered with a local distillery, Faber Distillery, who donated hand sanitizer. Currently, we have been able to buy and are giving away cold weather supplies to our populations in Kensington. And these include things like beanies and socks, hand and body warmers, and emergency blankets. So initially, our populations were homeless persons and persons addicted to drugs, mostly opioids, as we expected. But within a few weeks, we noticed a change in our study population. Other people started coming from the neighborhood and beyond in Kensington, from the neighborhood and beyond. In Kensington, there is a large population of people from Puerto Rico and the Caribbean. And these were people who needed to have these results for work or for travel or for whatever. And for many, we were the only option to get tested. And we realized quickly that we were no longer just a research project. We were a community service. We were a public service. This year, since January, this is where our sites are. We've opened up a new site in West Philly, which is right across the street from Presbyterian, and we're opening access to testing in this neighborhood, which is kind of a little bit of a testing desert. This was actually taken yesterday at our site. Yeah, it wasn't too bad, but that's what we do. We operate in a tent and we just go out there and we take care of business. Yeah, so in addition to our sites, we do so much more in our community. Like I said, we've become a public service and people find out about us and are calling us. I have people coming and calling me every single day for testing. They're coming to my lab. I'm going to their place, whatever is needed. One representative case I'm showing here, a friend and a neighbor of mine asked me for a test. She and her husband were feeling ill. She is a vet at the Philadelphia Animal Welfare Society, PAWS, which serves hundreds of people here in Philly from 2 clinics. So my friend Carrie and her husband came into my lab in the morning, and I was able to give them the results by 5 p.m. and they were both positive. By 7, I was on a Zoom call with her and the director and managers of PAWS here in Philly, and they were scrambling to try to contain the spread and they were kind of pouring through their schedules to figure out who was in contact with whom and etc. They actually did a fantastic job. But at the time, they were debating what to do. Should they close their clinics out of an abundance of caution? And they were asking me for my guidance. I'm just a lab guy, but I was thrust into this position where I can actually affect people's lives in real time. And I know how this must sound to a room full of healthcare workers, but this is not something that I'm used to. And really this newfound responsibility was and still is something that weighs very heavily on me. I'm not trained for this kind of stuff. Well, anyway, from this group, who we actually ended up seeing a few times, long story short, there was only one other positive person in their group, and they were able to isolate them and keep it from spreading to everyone else. So they were able to keep their doors open, and we were able to make sure that their doors stayed open and that all of their patients, well, I guess the owners of their patients, didn't really lose any time, which is amazing. This is just one example. We're doing this for a lot of different groups, including the Philadelphia Department of Public Health. They called us to see if we would go and test their offices because it was easier for them to get tests from us than it was for them to get tests through the city. That was, wow, that was amazing. All right, so what have we done over the last almost going on 2 years? Since June of 2020, we've interacted with more than 1,700 community members. And this is a low estimate, just based on the surveys that we've collected. We've done a lot more than what our surveys show. We've done over 1,300 real-time PCR tests since June of 2020, and that number blows my mind. All right, but just since July of 2021, we've given out close to 1,500 rapid antigen tests, and these are the ones that are provided by the city. So in a little over 6 months, we've done almost 1,500 tests. And over the course of this entire time, we've given out hundreds of harm reduction kits and resources to members of our communities. I didn't mention it here, but a big priority of ours is also addressing vaccine hesitancy. And so with every patient, we talk about vaccines, and if they are on the fence or want some more information, I've created a whole rapport about how to talk about about vaccines and to give out proper information and kind of debunk a lot of these myths. So vaccine hesitancy, harm reduction stuff, and then for people that want to be vaccinated, we can give out information and help them set up appointments. All right, some more data. So, all right, so the average age of our participants is about 42 years old, but you can see that the ranges span pretty broadly. With the rapid tests, we've been able to give those out to children since it's non-invasive and doesn't hurt at all. We've been able to give them to toddlers even. So in terms of our gender identities, about 2/3 of our participants identify as male, about 1/3 identify as female, and less than 2% did not identify as either of those. According to our ethnicity breakdown, the highest numbers of people that are coming to our testing sites, unsurprisingly, are people that identify as Black or Latino or white. I'm sorry, or white. This is, well, I'll talk a little about that later, but these are the 3 major demographics in our study. And these numbers are kind of on par for the city demographic information. According to the US Census data from July of 2019, white population in Philadelphia is about 41%. Hispanic is about close to 15%, and Black population is about 42%. So as you can see, our patient population for Latino are overrepresented compared to the population here in Philly, whereas the Black population is underrepresented according to our population here in Philly. Here's some more just information about demographics. As we see, we ask about highest level of education. And for the most part, about half of our populations have graduated from high school, but there's kind of the breakdown. And then lastly, importantly for our study, is the living situation. About 60% of our participants live in a residence, whereas almost 40% are experiencing housing insecurity, either living on the street or in a shelter, or other generally refers to things like crashing on someone's couch or something like that. So about 60% live in a house, about 40% are unhoused. Okay, so one of the goals of our study was, was to directly compare the results of the rapid tests with those of the real-time PCR test, the so-called gold standard. So this isn't the most updated, but what we see is that from over 600 participants who took both the RT-PCR and the rapid test. Oh no, just one second. Oh, there we go. From patients that took both the rapid and the PCR tests, we found that there's only been one false positive rapid test. That means that the rapid test said that it was positive, but when we did the PCR, it said it was negative. Interestingly, we did redo that test 2 days later with that same patient, and it was negative for Binax. It was negative for the rapid and negative for the PCR. So we think that that was probably an anomaly or an actual false positive that the rapid test provided. However, what we're seeing are 19 quote false negative rapid tests. What this means is that the rapid test showed a negative result, but the PCR test showed a positive result. This, however, is not surprising because some patients will continue to test positive with a PCR test weeks to months after their infection is over. And that's because some viral RNA particles can remain in your body for a long time, and that will cause a positive result in a PCR test. So that wasn't, that didn't surprise us at all. And that's good. What's kind of scary, however, is the difference between the infection rates that between the two tests. So if we're looking over here, what we've seen with the rapid tests is these really low positivity numbers. Again, these aren't the most updated. I don't think this includes January, which is a little higher, but still. The positive rate on the Binax test is much lower than what we're seeing in the PCR test. Since we started doing the rapid test, most people only do the rapid test because it's easier and faster, you know. However, what our data suggests, and it's reported from other reports as well, that rapid tests are less sensitive and it may not be detecting or missing positive cases. And this might have to do with timing, because for the rapid test to work, there has to be a certain threshold of antigen in your body before the rapid test can detect it. And that can take 4 to 5 days after your infection for your body to have enough antigen to actually show up on the test. However, so if you took that test earlier at say 2 or 3 days, on a Binax that would come up negative. But a PCR test taken at 2 or 3 days would detect a positive infection because it detects viral RNA, which as soon as the virus is made, it's there. So we're thinking that because the PCR test can detect a much lower level of infection, it can detect and can show the positivity much earlier, that we might be missing a lot of positive results because people are only doing Binax. And that has nothing, I'm not saying anything against the rapid test, but that's just the limit, that's just the limitation of that type of technology. All right, let's look a little bit at at our data over time. Let me just do something real quick. All right. Okay, so this the first graph here shows our results, our monthly results. On the y-axis is the number of participants. So blue will show the number of negative, and orange shows the number of positive results. And what you can see here is that we started with very few positives, and then it started to pick up. Where is it? There we go. Yeah, and then it started to pick up. Our positivity rates were pretty high in March and April. We were up at 11 and 15% positivity rates at that time, but then they kind of died down a little bit, and we were down at below 3% going into the fall. But then in October, we started to spike back up again, and we started seeing 10% and 8% in October, November, and then in December we were up above 20%, and in January we're at about 17%. So we're not out of the woods yet. We're getting more and more positive, and it's staying consistently positive, which is not good. According to our rapid tests, since we only started in July, again, we can see the same thing. We were pretty low until, starting in the fall. In October, we started at about 2%, and then rising to 3%. And then in December, in agreement with the PCRs, we were up above 14% and 15% in January. And we're only in February now. We've only done a few dozen tests, but we're at about 7% right now, positivity rates in February. Just more information about our demographics. So what we see is very high infectivity rates in Black and Latino populations. Well, in all of them, but mostly the Latino population. The Asian positivity rate here, I think, is kind of an artifact of the fact of the very few numbers of this population that we've received, that we've seen over the course of these last 6 months. So this is just kind of skewing the data. So I don't think this is actually true. I think this is just because of our just because of timing. And families would come in and they were all positive too. So I think this is kind of an artifact, but the rest shows pretty consistently. There seems to be a little bit higher trend for women getting infected versus men. This number doesn't seem like a lot, but it's kind of higher if we think about the totals that we're talking about. There are much fewer women enrolled in our study, but their positivity rates stays higher. We haven't had a chance to really start breaking down the data and looking at individual populations, really kind of extracting out the different populations. This is all complete data. We will have to crunch this and look more in depth into our different populations. Okay. Oh, the one other thing that I thought was interesting was that in our housing, with our housing information, the people that are infected, the people with the highest amount of infectivity are those that live in residences. By and large, people that are unhoused have very low positivity rates. The do not answers are kind of all over the place, but this mostly refers, well, it's kind of all over the place. We can't really parse that apart. But yeah, interestingly, people that are not living in residences have a smaller infectivity rate. Okay, so just to kind of conclude, my first conclusion is that the COVID-19 pandemic is not a hoax. But really, this project, we still need to analyze the data more deeply, but it's clear that that we're going to be seeing a lot of these tendencies in the data moving forward. And one of them is that those people identifying as Latino and Hispanic have the highest COVID-19 infectivity rates. And I mean, based on national data trends, this is not surprising. Our goal was to try to determine why this is the case. And we've gained some insight about this. Very briefly, the persons in these populations are less likely to be able to adhere to the guidelines that are aimed to prevent infection. So, these are the people that are not able to work from home and have to take public transportation and live in high density housing. Yeah. Conversely, unhoused people, like I just said, have the lowest infectivity rates. And this is in agreement with other studies here in the US and with a partnering group that we work with in London that show that because these people, by and large, live outside, don't live in densely, don't live in dense housing populations, and also they are well aware that this pandemic is happening, and they know that they do not want to get sick. So because of all of these things, people who are housing insecure tend to have a lower infectivity rate, which is great. So that's the data conclusions, but more general conclusions, I think, and some lessons that I've learned, at least, is that this really has to do with community research. And it's really two things. It's research on the community, or it's research with the community. I think that the former, it can be illuminated, but in the wrong hands, it could be paternalistic. Really, community-based participatory research, the with, is really the gold standard that any community-interested researcher should strive for. And this is research that's wholly based on community partnerships. That is the co-creation of knowledge that is relevant and meaningful to those that it involves and affects. It's difficult and not always possible, but nonetheless, it's the valuable gold standard. And we know that community research is both qualitative and quantitative. We know how important data is, and that can't be disputed. However, when talking about community, I firmly believe that most of this occurs when we are physically in the community, observing and making connections between the hard data and what's really going on in the lives of those that we're trying to serve. Community research cannot exist without being on the ground and experiencing the lives of those people who you're trying to learn from. You have to remember that they are the ones that are providing us with the data. They are the ones that are going to show us how effective or ineffective interventions are going to be. And they're the ones that are going to tell us what's really needed, as opposed to what someone else thinks that they need. So when I was talking, so my title is really about this. It's about what I think is important with doing this type of work. And even though I've been doing it with COVID and COVID testing, I think that this applies to any kind of sort of community outreach that we try to do. So with that, I would like to just acknowledge all the amazing people that have helped to create this project and continue to help create this project. And that includes Prevention Point of Philadelphia, the clinic in Kensington that we work very closely with, the Philadelphia AIDS Consortium, Community College of Philadelphia, all the volunteers at all of these different organizations that have come together to help, all of the RAs and volunteers who have helped, and just everyone who has helped put this thing together. Now, I'm happy to take questions on this, but I would like to take just the next, hopefully 10 to 15 minutes and talk about a project that I'm working on now. And it's kind of got bigger implications. And I think that this is the right group to bring this up with. So if it's okay with you, I'd like to keep going and introduce this new project, and I hope that it kind of speaks to some of you. So for this project, I am trying to find the correlation between chronic environmental stress and trauma outcomes, and I'll explain what that means in a sec. This is just this is an intro slide to traumatic injury and trauma-induced coagulopathy. So traumatic injury is the leading cause of morbidity and mortality in people under the age of 50. And in our country, it represents 10% of all medical expenditures. Hemorrhage is the principal cause of preventable death during traumatic injury. The majority of post-traumatic bleeding is non-coagulopathic, meaning normal bleeding that can be controlled with compression or embolization or sutures. But about 25% of patients will come in with a trauma-induced coagulopathy. So coagulopathic bleeding is different. It's a complex clinical state that's characterized by the failure to form hemostatic clots. This can be really bad because this is really bad because this results in diffuse bleeding, and it's extremely difficult to stop. And it leads to increased mortality. Mortality from blood loss can occur quickly, with 80% of people dying within the first 2 hours of hospital presentation. And there's a number of mechanisms that attempt to describe the pathogenesis of trauma-induced coagulopathy, but one proposed mechanism is platelet dysfunction. Indeed, platelet dysfunction is an early marker for trauma-induced coagulopathy and is used to help direct patient care and help identify those that are at risk from hemorrhage. So I was going to go through and talk a little bit about platelets, but I'm just going to fly through these. I hope all of us know that platelets are important for blood clotting. This is what they look like when they are unactivated, kind of in their ready mode. They have granules that release immune factors. Once they're activated, their shape totally changes. They put out these pseudopodias that can now bind to cell walls at the injury sites, for example, or it can bind to other platelets. It can bind to fibrin, all this stuff to form a clot, and that's what happens. Also, there are granules inside of platelets that release a bunch of immunological factors and inflammatory factors, and that helps form a clot. So all of this is obviously terribly important, especially in a patient that's coming in bleeding. So we can measure the strength of the clots, of how well a clot can form, using thromboelastography, TEG. This is a cartridge-based system that uses different activating stimuli to measure clot strength. This is our research bay. We're located right off the trauma bay. So literally, if we were looking at this, right behind us is the trauma bay. So we can collect blood, immediately come over here and measure the clot strength of the patient's bloods. And what the readout is, it gives us this kind of information. With different activators, these clots are going to form, and we can look at different components of it. But really what we're looking at is what's called the MA, the maximum amplitude. And this really just discusses, this tells us about the strength of the clot. And so with this in place, we can start looking at platelet function following a traumatic injury. So the first question we said was, well, how prevalent is platelet dysfunction in our trauma population group? And this was a retrospective study that was done by one of our members of our research team, Julie Kim, who is now in her second year of med school at Jefferson. So this is one of our studies. This was done looking at adult trauma patients that were involved in this study called TRISI, Trauma-Induced Coagulopathy and Inflammation. And this is between March 2017 and March 2019. So what we do for this study, we collect blood samples at designated times, at arrival, T0, and then at T 3 hours, 6 hours, 12, 24, and 48 hours. And at each point, we run this blood over to the TEG and analyze it. And we determine abnormal TEG or a platelet dysfunction as anything below 40 millimeters as an MA. Right. And in addition to the blood, we also collect all vital signs, ins and outs, clinical labs, the amount of blood products that are transfused. All clinical data is collected in real time and stored. So what we see is that of 93 patients that were in as part of this kind of our cohort, we saw a platelet dysfunction in 64.5% upon admission. That is really high. Further, people that had these platelet dysfunctions were associated with higher injury severity scores. So these are our patient population. These are the patients that have platelet dysfunction. These were the ones that we didn't. So those with platelet dysfunction had higher ISS scores. They were also more associated with penetrating injuries. Sadly, if we look down here, there's also people with platelet dysfunction also have a higher, have increased mortality at 24 hours and at 30 days. A few more things. Patients with platelet dysfunction also had slightly lower lactate levels at admission and pH, which is notable because, I mean, we're not going to talk about this now, but platelets secrete lactate dehydrogenase from their granules when they're activated. And this leads to the accumulation of lactate and the drop in pH, which is something that we're seeing here. So that's kind of interesting thing to think about. So I'm not going to talk about this whole study, but you know, the main point is that there is a high incidence of platelet dysfunction in our patient population. The rest of the study went on to show that I was able to do a lot of functional and mechanistic experiments, looking at how well these platelets can do their functions, like aggregate and form clots and all these things. And I was also able to look at mitochondrial function and measure, do some gene expression stuff and measure NAD levels, all these things. But I'm not going to talk about that now. But that's what I'm doing on a study that we're doing now. This is a DoD-funded study called CHIPS. And this is a phase 3 multi-center international randomized partial blinded adapted non-inferiority storage non-inferiority clinical trial that's looking at how well it's looking at the storage parameters of transfused platelets. So that's cool because I can get to do the same thing. I can take these stored platelets, transfusion bags, and measure all of their different parameters to see how well they're working. So it's cool because I have all of the infrastructure in place to really do in-depth analysis of platelet function. And so I'm proposing a small pilot study that I hope turns into something much bigger. So my question started with, why is our platelet dysfunction so prevalent in this community? You know, this is not an easy question to answer. One, because there isn't a lot of information about platelet dysfunction in trauma in general. There's just not a lot of information there. the one study that I was able to find showed that 38% of people can develop abnormal platelet functions. However, this was performed. This has some caveats. For one, this is performed on a device called the PFA 100, which is kind of a precursor to our tech machine. So the machine itself is different, but more different is that this study population was with over 1,000 adults who live in the city of Lübeck in northern Germany. So this is a city of 250,000, and it's mostly rural. The average age there is about 61. So, you know, it's not a direct comparison. But it was a population-based approach, which makes these results applicable to us a little bit. So, all right, that is still a much lower number than our, 64%. So, I mean, there are inherited disorders of platelet function, but those are very severe, and the phenotypes would have shown much earlier than when they received than their trauma. So to try to sort of explain this, I've turned to kind of this, what's called psychoneuroimmunology. Long story short, chronic stress is bad. There are different types of stress in our lives. There's good stress, but there's also toxic stress. And stress is really defined as an environmental stimuli which threatens an organism's homeostasis. All right, cool. Allostasis down here refers to the process where an organism adapts to a stress. That is, it changes in its internal parameters to maintain physiological stability to match whatever the physiological demand or the environmental demand is. Okay, so that's allostasis. But the perception of stress. So when you have stress, the perception of stress is really it's going to be influenced by the person's experiences or the genetics, behavior. When the brain perceives stress or a dangerous situation, physiological and behavioral responses are initiated, which leads to adaptations, allostasis. Over time, this allostatic load can accumulate. And this is the wear and tear that the body experiences when repeated allostatic responses are activated during stressful situations. So this resulting overexposure to mediators of neural, endocrine, and immune stress can have adverse effects on various organs that can lead to dysfunction or disease. So the most common allostatic responses involve the sympathetic nervous system and the HPA, the hypothalamus pituitary adrenal axis. Just really quickly, for these systems, stress activation, once it's perceived in the brain, releases neural stress responses mediators that can then target the pituitary gland, and then things from the adrenal gland are released, like cortisol, or other things from the sympathetic nervous system can cause the adrenal gland to release epinephrine or norepinephrine, things like that.
Antonio, just sorry to interrupt. That we have like 7 minutes left, and I want to make sure that we have just a few minutes for questions or something. So if I can ask you to wrap up in the next.
Yep, I'm going to finish in the next 2 slides. Yeah,
wonderful. Thank you.
Okay. Thank you. Sorry about that. Yeah. So normally a threat would eventually end, and the response signal would stop, and then the organism would recover. But chronic stress, however, continues and is a continued stress. So the prolonged activation state can have a domino effect that can affect a bunch of different biological systems. Indeed, platelet exhaustion is similar to other types of cells that have these that release granules and stuff. And yeah, so my proposal is that chronic environmental stress from living in these stressful communities is directly contributing to the prevalence of platelet dysfunction and mortality rates in our trauma population. So what I'm proposing to do is analyze the serum and plasma of our samples for neural stress and immune markers, and then assess the patient's family, the patient and their family for stress markers. That might not be possible because of the IRB. I might need to use what's called GIS mapping, or geographic information systems, which allows you to visualize your data from a map. And then I can use city information from zip codes to assess stress. So what I have is the complete clinical data for each of these patients. I'm focusing on mortality, but there's dozens of parameters that we can look at over time. This data set is ripe for a retrospective study. Just saying, if anybody's interested, we have the data. For the immune dysregulation, I can use ELISAs or another technology called the quanteric Simoa to look at all different kinds of immune markers, including IL-1 beta, IL-6, IL-8, 10, a bunch of other stuff. Same goes for neural stress markers. I can use the same technologies to look for things like cortisol and epinephrine and stuff like that. The question for me is how to accurately assess chronic stress. I've been lucky that people have helped. I've read some papers and have some instruments for different types of stress, but I'm really looking for help to really learn how to quantify this better in this population. So I'm open for help and suggestions. And I appreciate your time. I'm sorry that we went a little over and that I talked a lot about a lot of stuff, but please feel free to email me and we can talk further.
Thank you very much, Antonio. Bravo. There's tour de force and wonderful work, and wonderful to see your passion about the community work, but also the scientific part that probably is informed by a lot of what you see in the community, no? And so it's very important. I'm for those of you who don't know me, I'm Mariana Lasso. I'm professor at Drexel, and I'm going to be moderating just the questions and this part of the discussion. If people have questions or comments, you can write them in the chat. So while people have questions, I wanted to, first of all, really congratulations. It was incredibly inspiring, all your effort with the community, with the Latino community, how it seems it was a transformative experience for you and the team, but also, it's the ability of transform and respond to the pandemic, quite incredible. And I can see how being trained in very lab work, all the chaos that was at the organizational level and at the public health infrastructure, just encountering that, how it was daunting, but at the same time you never gave, you and your team never gave up. And I think we can all speak of the importance of having good teamwork, so that when you are facing all these challenges and barriers, you have that energy and also the needs from the community that give you more energy to continue, no? and never give up. I have congratulations also on making it. I see you have multiple missions. You have the service mission that you're clearly filling very important gaps, and also your research aspect of it, and it was quite visionary to obtain some data from the community. One is a comment. One would be that when you're comparing a lot of the positivity rates that you're observing in your sample, it may be useful to compare to the citywide, so that I think we can draw some conclusions by looking at positivity rate in your specific areas and in your specific subpopulations, vulnerable populations, as compared to the overall population in Philadelphia. The fact that you didn't have a lot of black people. I mean, it was 18% of the people who attended the testing sites were blacks. And I wonder if you can tell us a little bit about other efforts that were going on in the community, like the Black Doctors Coalition, and to what extent, tell us a little bit about the collaboration, or, with
or
other.
lack of.
Or lack of, yes.
Well, I can tell you that we started well before Black Doctors Consortium. That was when that came out. I was like, oh, finally, thank goodness. Yeah, we started right away, and so we didn't really have anyone to ask. Our big push was trying to find, once the vaccine started, our big push was trying to partner with a vaccine group. And we did. For some time, we partnered with Drexel Vaccine Group, and they were at the Love Lot with us. However, they were only there for a few months. I don't know if their funding dried up, or I don't know, but for a little while, it was fantastic. It was so successful because people trusted us, first of all, because we'd been there for a while. And so they would trust us. And when we asked about vaccinations, often they didn't know about it. They were scared, they had issues. And so it was really on us to convince them to get vaccinated. And so being able to talk to them, and they trust us, and then walk them over to the vaccine tent and talk, do sort of what's called a warm handoff, and introduce them and have everyone talk. I'm so proud of that aspect of it, just being able to, and it continues, being able to convince people to get vaccinated is a huge priority. I know that wasn't your question, but but in terms of partnering, that's really who we tried to partner with. The other people that we partnered with are tangentially groups that are doing things like food distribution and clothing distribution and stuff like that. We partnered with them just so that we can build a little bit of a hub, so that people from the community can go to one place and get food and get clothes and get tested. So that's kind of that's who we're partnering with most. We help out other testing groups and stuff if we can, with information and stuff, but we're really kind of a little our own little group.
Yeah. There is a question in the chat about where do you see yourself at the break? You spoke about the next phase and continue to providing services and expanding it. So tell us a little bit.
For the next 6 months, we're funded to continue this through the city, so that's good. Not to sound cynical, but I don't know what you mean by once the numbers have settled. I'm just being facetious. I don't think that COVID is going to be over. I mean, it's something that we're going to have to learn to live with. I'll be fully honest, and I'll tell you that I am sick of COVID. I'm tired of this. I'm doing it because it's important, and I think it's important work. But I'm like everybody else. I'm sick of this. I don't want to do this anymore. So after this next 6 months, I don't know. I'm pushing to not apply for a renewal because this is impacting my work. I mean, I am not a COVID guy. I will publish a couple of things on this, but this is not my work. I'd like to get back to my work. And so, yeah, to be totally honest, I'm hoping to extricate myself from this project this year and really get back to what I do.
Thank you. Well, that was wonderful. No, I'm sure this was very inspiring, and I'm sure you have planted lots of seeds too, and I hope that they have learned from your experience, and then they can continue to build upon that. But again, I want to we're run out of time. I will get back to you about some of the questions that you have for your second project. That was very interesting, and I'll be happy to connect with you about that. But thank you again very, very much for such an inspiring talk, all the work, very important. That's on my behalf. I greatly enjoyed the talk, but Anna, who had to leave early, also said the same thing. And I'd like to remind the attendees of our next MERC colloquium, which will be March 4th. And we will have, the speaker is Dr. Yetza Bojorquez del Colegio de la Frontera Norte. So please join us. And Cata, I don't know if we have any other announcements or anything that you want to add. Again, please join me in thanking Dr. Antonio Dávila, and see you. Be well, take care, and see you next month.
Thank you so much. This was a lot of fun.
Wonderful.
Nice meeting all of you.
Thank you, Antonio, and I'll get to you. I'll send you an email. We'll follow up.
Okay.
Bye,
Bye,
everyone.
Bye.